This programming is brought to you by Boehringer Ingelheim Pharmaceuticals Incorporated. Heart failure guideline-directed medical therapy offers an opportunity to provide better care for patients, but significant gaps in uptake remain. Now more than ever, it's time to pump up GDMT for heart failure. Leaders in the cardiology community recognize this need and are asking you to do the same. Visit pumpupgdmt.com to learn more. Together, we can help ensure guidelines are enacted and patients receive quality care.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. Dan Ambinder here, and this episode is part of a series of fascinating case reports developed in collaboration between CardioNerds and the National Lipid Association with mentorship from Dr. Daniel Sofer and Dr. Eugenia Gianos. The National Lipid Association runs a Lipid Scholars Program, which aims to mentor and educate trainees to work towards certification during their training, getting more certified lipidologists and preventionists into clinical practice and out in the world. So, for this CNCR sub-series, we're going to be focusing on cases that are put together by NLA Lipid Scholars. And so, without further ado, let us introduce today's scholars. That's going to be Dr. Spencer Weintraub, Dr. Michael Albosta, and registered dietitian nutritionist Anna Biggins. Spencer, Michael, and Anna, why don't you go ahead and introduce yourselves and let us know how you joined the NLA and how the Lipid Scholar Program fits your career goals.
Hi, everyone. My name is Spencer Weintraub. First off, a huge thank you to the CardioNerds team for giving us the opportunity to discuss our case. I'm currently a chief resident at Northwell Zucker School of Medicine, Internal Medicine Residency Program. And I'm starting my cardiology fellowship at Northwell North Shore University Hospital and Long Island Jewish Medical Center. I've always been very passionate about exercise, diet, and incorporating lifestyle changes to improve cardiovascular health. Through the mentorship of Dr. Hirsch and Dr. Gianos, I became involved in the National Lipid Association and prevention research. Becoming part of the Lipid Scholars Program gave me the opportunity to interact with leading prevention experts, access to amazing resources, and an opportunity to grow my knowledge for my future career as a preventive cardiologist and lipidologist after fellowship.
Hi, everyone. My name is Michael Albosta. I'm currently finishing my third year of internal medicine residency at the University of Miami and will be starting cardiology fellowship at the Mayo Clinic in Rochester, Minnesota. I've always been passionate about cardiovascular disease prevention, and with the help and direction of my mentors, I joined the NLA's Lipid Scholarship Program in an effort to gain the knowledge, resources, and mentorship that will help me in my journey towards becoming a preventive cardiologist. I'm very excited to be reporting with you all today, and thank you so much for having me.
Hey everyone, I'm Anna Biggins, and I'm a registered dietitian nutritionist at the Georgia Heart Institute in the Center for Cardiovascular Prevention, Metabolism, and Lipids. I hold a master's degree in public health, and I completed my dietetic training at Kansas State University. And I originally got into dietetics because of my passion for using food as medicine to prevent chronic disease, and the NLA really prioritizes lifestyle modification as the foundation of interventions to improve heart health. So I'm really grateful to be a part of the group, and thanks so much for having me.
Well, let's get started with our case. Our patient is a 32-year-old female who presented to our emergency department with 1 day of sharp epigastric abdominal pain. She describes the pain as constant and radiating to the back. Her pain was associated with nausea, as well as several episodes of non-bloody, non-bilious emesis. Finally, yesterday, she noticed the abrupt onset of a new rash on her knees. In terms of her past medical history, she has a history of HIV, type 2 diabetes, and polycystic ovarian syndrome. She has previously been told of elevated cholesterol levels. However, we do not have a previous lipid panel available for review. With regards to her family history and social history, she has a sister who is currently being treated for high triglycerides. Her mother unfortunately passed away at age 55 of an unknown malignancy, but also suffered from high triglycerides. She also has 2 maternal aunts with high triglycerides and premature coronary artery disease, suffering from myocardial infarctions in their 50s. She's a lifetime non-smoker, does not drink any alcohol, and does not use any illicit substances. She's currently taking metformin 1,000 milligrams twice daily, bictegravir, emcitrabine, and tenofovir alafenamide, and a combined oral contraceptive. She has no known drug allergies.
Michael, that was a lot of useful information. To summarize, our patient seems to have presented with a very abrupt onset gastrointestinal symptoms and a new rash. While the differential diagnosis for a nonspecific abdominal symptoms is broad, her past medical history is full of very useful information that may help us narrow down the potential etiologies. So Spencer, why don't you help us walk through what you are thinking at this point in this case?
Thank you so much. As you mentioned, the differential for her epigastric pain, nausea, and vomiting is broad and includes pathologies such as pancreatitis, gastroenteritis, colitis, and gallbladder diseases such as cholecystitis and choledochocolitis. Although less likely, some cardiac etiologies to consider would be aortic dissection or an atypical presentation of acute myocardial infarction. Other less common differentials would include small bowel obstruction as well as inflammatory bowel disease. The addition of the rash is interesting, and at this point, it is unclear whether or not it's related. However, it did develop abruptly around the same time as her abdominal symptom, which makes us believe that this is part of a broader disease process. At this point, her past medical history and family history can really help us shift our focus to a few specific etiologies. Although she is young, her history of HIV and type 2 diabetes, as well as polycystic ovarian syndrome, are all risk factors or risk enhancing factors for atherosclerotic heart disease. They are all also associated with metabolic dysfunction and dyslipidemia. This becomes even more important when we consider her family history, with several family members who have been specifically treated for elevated triglycerides, two of which suffered from premature ASCVD events. There's an interesting relationship between hypertriglyceridemia and ASCVD. Michael, do you mind talking a little bit more about this relationship?
Sure. Elevated levels of triglycerides have been found to be causally associated with ASCVD. This relationship has been shown in Mendelian randomization and epidemiologic studies, as well as through randomized controlled trials, given the positive results of the REDUCE-IT trial. It is important to note that this relationship is complex, as therapeutic intervention with icosapent ethyl in the REDUCE-IT trial reduced ASCVD events independent of triglyceride lowering. Additionally, it is worth noting that elevations in triglycerides are often accompanied by a decrease in HDL, and low HDL is associated with an increased risk of ASCVD events. Some epidemiologic studies have shown that the relationship between triglycerides and ASCVD is eradicated when adjusting for low HDL. There are several proposed mechanisms for the association between elevated triglyceride levels and ASCVD. First, elevated triglyceride levels correspond with high levels of circulating triglyceride-rich lipoprotein particles, also known as remnant cholesterol. This includes VLDL, IDL, and chylomicron remnants. These particles are thought to be at least as, if not more, atherogenic than LDL cholesterol. Remnant particles readily penetrate the arterial wall, similar to LDL, but do not require oxidative modification for macrophage uptake and can be taken up in an unregulated fashion, leading to foam cells and atherosclerosis. Second, having elevated levels of triglyceride-rich lipoproteins is pro-inflammatory. When triglyceride-rich lipoproteins are hydrolyzed by lipoprotein and endothelial lipases, the release of oxidized free fatty acids along the endothelial wall leads to the activation of pro-inflammatory signaling pathways that can increase vascular permeability and promote the migration of leukocytes and atherogenic lipoprotein particles into the arterial wall. This is mediated by cytokines and chemoattractant proteins. As you can see, elevated triglyceride levels can be a major problem.
Yeah, I definitely hear that. So, that was a great overview on triglycerides, and I feel like I'm really, really ready to absorb what comes next. But thinking about our patient, it sounds like they had several risk factors associated with elevated triglycerides. And so it would be helpful to know about lifestyle factors, medical conditions, and medicines that have been shown to raise triglycerides. So, Spencer, do you think you can take us through some of that?
Sure. Thank you so much. I'd be happy to. So, there are several lifestyle factors and clinical conditions that are known to be associated with elevated triglycerides. Leading a sedentary lifestyle and excess alcohol consumption are commonly associated with elevated triglycerides, and we see this very prominently. In addition, clinical conditions such as obesity, diabetes, chronic kidney disease, nephrotic syndrome, hypothyroidism, autoimmune diseases, hematologic cancers, and even pregnancy have also been associated with high triglycerides due to various mechanisms. Our patient has diabetes, and in diabetes, hyperinsulinemia stimulates the transcription factor SREBP1C, which leads to an increase in transcription of genes that promote hepatic lipogenesis. Additionally, insulin resistance also promotes the release of free fatty acids from adipose tissue, increasing the triglyceride. Also, our patient has HIV, which is commonly associated with hypertriglyceridemia and low HDL. These changes to lipids in patients with HIV are primarily due to pharmacotherapy and can be due to NRTIs, NNRTIs, and protease inhibitors, which can raise the triglyceride by multiple mechanisms. Additionally, antiretroviral therapy can disrupt glucose metabolism and increase and redistribute adiposity, which can contribute to a patient's development of metabolic syndrome and insulin resistance. There's also a component of chronic inflammation that can, in some instances, raise LDL-C levels, although this is variable based on different patients' genetics. In chronic kidney disease and nephrotic syndrome, it is thought that elevated triglycerides are a result of reduced clearance of triglyceride-rich lipoproteins by multiple mechanisms. First, there are elevations in ApoC3, which is a known inhibitor of lipoprotein lipase, a key enzyme in the breakdown of triglyceride-carrying particles. Nephrotic syndrome is also associated with upregulation of the angiopoietin-like protein 3, which also inhibits lipoprotein lipase, and this can result in increased triglycerides and atherogenic lipoproteins. So those are two mechanisms which inhibiting or deactivating the lipoprotein lipase enzyme. Similarly, hypothyroidism contributes to hypertriglyceridemia through decreased activity of lipoprotein and hepatic lipolysis. Pregnancy is another state in which hormonal changes contribute to the development of hypertriglyceridemia and hypercholesterolemia. Triglyceride levels in pregnancy are known to rise significantly, especially during the third trimester. It is thought that increases in estrogen levels decrease hepatic lipase activity, leading to reduced hydrolysis, VLDL, HDL, and LDL. Estrogen also increases hepatic triglyceride synthesis and VLDL production. Finally, insulin resistance in the third trimester leads to an increase in the release of free fatty acids from adipose tissue. Autoimmune diseases such as rheumatoid arthritis or psoriasis and hematologic malignancies such as paraproteinemias all have also been implicated in elevating triglycerides. Lastly, there are also several medications that have been known to raise triglyceride levels. These include thiazide diuretics, beta blockers, oral estrogen preparations, corticosteroids, antipsychotics, certain antidepressant medications such as mirtazapine, immunosuppressive agents such as cyclosporin, sirolimus, and everolimus, retinoids, which are used to treat acne, propofol, and lastly, protease inhibitors, which are a key treatment, as we mentioned, for HIV.
Wow, that was an extensive overview. So it looks like our patient has plenty of risk factors in her history for elevated triglyceride levels. And then given her presenting symptoms, I'm starting to worry more about acute pancreatitis. However, I think we need some more information in order to really understand what's going on. Michael, can you tell us more about her physical exam findings?
At arrival to the emergency department, she was afebrile, normal tensive, with a blood pressure of 130/82, mildly tachycardic with a heart rate of 100, and was saturating well on room air. Her BMI was 33. She had rounded facies, and mucous membranes were dry. She did not have xanthelasma or corneal arcus. Notably, a fundoscopic exam was not performed in the emergency department. She was breathing comfortably with clear breath sounds, and her cardiac exam was notable for irregular tachycardia. There were no murmurs, no carotid bruits, and no JVD or pedal edema. Her abdomen was soft with mild epigastric tenderness. There was no striae and no hepatomegaly. Murphy's sign was negative. Finally, on skin examination, she was found to have numerous small, clustered 2 to 5 millimeter papules on the extensor surfaces of the bilateral lower extremities.
Well, her exam is pretty nonspecific, but there are some notable findings. Her vital signs are pretty reassuring, although she is mildly tachycardic. Perhaps this is related to pain or hypovolemia, given her dry mucous membranes. She does have an elevated BMI and round facies, which could be related to her BMI or be related to an underlying endocrinopathy. Her cardiopulmonary exam is also very reassuring. However, given her risk factors, I would like to see an EKG and cardiac enzymes to feel comfortable that we're not dealing with an atypical presentation of ACS. The abdominal examination with the epigastric tenderness and the negative Murphy sign might make us slightly less suspicious for gallbladder pathology like cholecystitis but I would love to see the remainder of her workup before we can really know for sure. Finally, this rash is certainly an interesting twist. Mike, can you tell us a little bit about the diagnostic data?
Sure. Upon collection of her blood tests in the ED, it was noted that her serum was lipemic. Her CBC was remarkable for a leukocytosis of 15,000 with a normal hemoglobin and platelet count. Her metabolic panel was significant for hyponatremia with a sodium of 123 millimoles per liter. Potassium was 3.9 millimoles per liter. BUN was 6 milligrams per deciliter, and creatinine was 0.59 milligrams per deciliter. Her glucose was 309. Her transaminases were normal. Her calcium was also normal at 9.8 milligrams per deciliter. Her lipase was greater than 3 times the upper limit of normal at 186 units per liter. Her hemoglobin A1C was found to be 11.9%. Her lipid panel was significant for a total cholesterol of 680 milligrams per deciliter, with an HDL of 10 milligrams per deciliter and triglyceride level of 4,425 milligrams per deciliter. Finally, troponin I was negative with a value of less than 0.012 nanograms per milliliter.
All right, team. I feel like with all of this information, we have confidence in making our diagnosis of acute pancreatitis secondary to hypertriglyceridemia. And with the constellation of symptoms, exam findings, and lab evaluation, I think we're pretty suspicious of chylomicronemia syndrome as the etiology for all of this. So, this has been drilled in from, medical school and onwards about the consideration of elevated triglycerides as part of an evaluation for acute pancreatitis. So Spencer, I would love it if you could tell us more about how elevated triglycerides leads to pancreatic injury, what's the mechanism, and what are some of the exam findings that would be common with chylomicronemia syndrome that would help kind of put a Occam's razor on all of this?
Absolutely, I'd be happy to. So the exact mechanism is not totally clear. The proposed mechanism is that when serum triglycerides exceed 1,000 milligrams per deciliter, there starts to be impaired blood flow through the capillary bed supplying the pancreas, which results into ischemia. The ischemic injury resulting from this disruption of the microcirculation in turn disrupts the acinar structure of the pancreatic cells, and this exposes pancreatic enzymes to the triglyceride-rich particles. This results in activation of enzymatic activity with degradation of the chylomicron triglyceride particles, which causes inflammation, subsequently leading to hemorrhage, edema, necrosis, and ultimately destruction of the pancreatic tissue. In terms of common exam findings, some specific findings that you should note are eruptive xanthomas and lipemia retinalis. Lipemia retinalis can be observed on your ophthalmologic exam. Eruptive xanthomas typically occur when triglycerides exceed the level of 2,000 milligrams per deciliter and typically manifest as papules with a yellow hue that usually is on the extensor surfaces of the body. Although our patient's rash could have been eruptive xanthomas, this would be atypical as the most common locations typically are the buttocks, the back, the neck, and the elbows, rarely ever involving the lower extremities. Lipemia retinalis can be visualized on fundoscopy with a pale pink or creamy white appearance with loss of the ability to differentiate the veins and the arteries. Other non-specific exam findings that you might see in these patients include hepatomegaly, splenomegaly, or even confusion.
Wow, thank you for that, Spencer. So now that we've talked about the mechanism and your physical exam findings, can you tell us more about how we should consider management for this patient in the acute setting?
Sure, I'd be happy to. So obviously in this case, once we have identified hypertriglyceridemia-induced pancreatitis, we need to target both the underlying hypertriglyceridemia and manage the pancreatitis. So for pancreatitis, we're going to start with IV fluids and pain management, which should be initiated early. The recent waterfall trial supports moderate fluid administration of 10 milliliters per kilogram bolus, followed by a 1.5 mil per kg maintenance until the patient reaches euvolemia. In terms of the specific management of the triglycerides, in the setting of acute pancreatitis, the treatment options usually include insulin infusion with or without a heparin drip versus using plasmapheresis. The insulin works by activating lipoprotein lipase, which we talked about earlier, which breaks down the chylomicrons and assists with chylomicron clearance. This can also be helpful for rapid glycemic control, as many of the patients with hypertriglyceridemia-induced pancreatitis also have concurrent insulin resistance and diabetes mellitus, as seen in our patient. In terms of the heparin infusion mechanism, this is a little less done commonly because it can cause rapid endothelial release of lipoprotein lipase, which would theoretically augment insulin, but this can also deplete your lipoprotein lipase stores. And so this is very controversial and is not done in most countries. Plasmapheresis, on the other hand, works by removing the triglycerides from the blood itself. There has never been a randomized controlled trial to assess which treatment is superior, but I will note there was a recent meta-analysis published in the Annals of Gastroenterology, which showed no difference in mortality, hypotension, hypoglycemia, or acute renal failure between insulin plus or minus heparin or plasmapheresis. Although mortality was lower in the insulin infusion arm, and hypotension, hypoglycemia, and acute renal failure was less common in the plasmapheresis arm. Neither of these findings reached statistical significance. Hypertriglyceridemia in pregnancy presents an additional challenge, as this carries a very high maternal and fetal mortality. Estrogen levels are at their peak in the third trimester of pregnancy, which results in, like we discussed, that enhanced lipogenesis, suppression of hepatic lipase, and decreased lipoprotein lipase activity and insulin resistance. The combination of these physiologic changes result in a 2 to 4-fold increase in triglyceride levels. High triglycerides increase the risk of fetal macrosomia and preterm delivery. Plasmapheresis is considered first line in this population, as a lower incidence of systemic inflammatory response syndrome was noted in case reports and case series in pregnant patients. In addition to medical management, dietary intervention plays a critical role in both the acute and long-term management of these patients with acute hypertriglyceridemia-induced pancreatitis and chylomicronemia syndrome. Anna, would you mind telling us a little bit about how you would manage this patient from an inpatient setting in terms of their diet?
Absolutely. So, inpatient dietary management and hypertriglyceridemia induced acute pancreatitis is actually not well defined in the literature or in guidelines. Obviously, fluid therapy is essential, but there's actually more debate over the topic of pancreatic rest. On the one hand, the 2018 guidelines from the American Gastroenterological Association give a strong recommendation for initiating feeding within 24 hours as tolerated, rather than keeping the patient NPO for an extended period of time in acute pancreatitis. However, that guideline was not developed based on patients with hypertriglyceridemia-induced acute pancreatitis. So the rationale for early feeding is that there's about a 2.5-fold higher risk of infected peripancreatic necrosis and needing interventions for necrosis, as well as a 2-fold higher risk of multiple organ failure and total necrotizing pancreatitis if feeding is initiated after 24 hours. But on the other hand, reducing triglycerides as quickly as possible is also a priority because of the increased risk of persistent organ failure with hypertriglyceridemia in acute pancreatitis. So the odds ratio of persistent organ failure with acute pancreatitis is 2.6 for moderate hypertriglyceridemia, and it jumps up to 4.9 for severe hypertriglyceridemia. Triglycerides will rapidly decrease with fasting by as much as 50% per day of NPO status. So in this case, I do think it would be best to keep the patient NPO until there's a significant reduction in triglycerides, not necessarily until they reach normal levels, but preferably below 500 milligrams per deciliter, as that's the threshold for LPL saturation. And then once triglycerides are sufficiently lowered and the patient can tolerate food, then we would want to initiate a low-fat, low-sugar diet. And that's because dietary fats and carbohydrates are some of the key regulators of ApoC3 expression in hepatocytes. As you mentioned earlier, Spencer, ApoC3 inhibits the action of lipoprotein lipase. So from a dietary standpoint, saturated fats, glucose, and fructose enhance the expression of ApoC3, which then inhibits the action of LPL, leading to a buildup of triglyceride-rich VLDL and chylomicron remnants. As far as these sugars go, fructose is a simple sugar that has a greater stimulating effect on ApoC3 as compared to glucose. Fructose is found in fruit juices, soda, and other sweetened beverages, like think of the high fructose corn syrup used as a sweetener in many soft drinks. Fructose also induces hepatic de novo lipogenesis, which, knowing that she has type 2 diabetes, which already induces more hepatic lipogenesis, the fructose will essentially contribute even more to the overproduction of triglycerides. So whenever she gets taken off of NPO status, we would definitely want to leave off the orange juice, soda, sweet tea, or flavored milk off of that hospital meal tray for this patient. And then also, while glucose and fructose enhance ApoC3 expression, polyunsaturated fats and insulin inhibit it. So once we inhibit the expression of ApoC3, that actually increases the action of LPL, lipoprotein lipase, leading to a greater clearance of VLDL and chylomicron remnants. So these polyunsaturated fats, one of them is eicosapentaenoic acid, or EPA, which is a powerful omega-3 fatty acid that lowers triglycerides in a dose-dependent manner, as mentioned earlier. Salmon, mackerel, anchovies, sardines, and herring are some of the richest sources of marine-based EPA. And then we can also get plant-based sources of omega-3 fatty acids from chia seeds, flax seeds, and flaxseed oil, nuts, canola oil, and soybean oil. And all of these plant-based sources contain alpha-linolenic acid, or ALA, which is then converted to EPA and DHA through different processes of desaturation and elongation in the liver. So a low-fat, low-sugar diet will help during the inpatient stay after NPO status, and then this will also be a cornerstone during outpatient management of hypertriglyceridemia, which I think I'll touch on a little bit later.
Oh, Anna, that's a masterclass in dietary considerations when it comes to hypertriglyceridemia. And I just love this multidisciplinary approach to the patient. So clearly what I'm getting is that adherence to a strict dietary regimen is critical in the management of patients like this. And so we should be reaching out to our registered dietitians, especially those with experience managing lipid disorders early in the management course when caring for patients like this. So Michael, can you tell us more about the patient's clinical course and how you ended up managing the patient?
Of course. Our patient was made MPO initially and was fluid resuscitated with a 10 ml per kilogram bolus, followed by initiation of maintenance fluids at 1.5 mLs per kilo per hour. Her pain was adequately controlled with IV analgesics, and she was started on an insulin drip to both improve her glycemia and enhance lipoprotein lipase activity. In addition, the decision was made by the ICU team to initiate plasmapheresis to more rapidly clear her serum triglycerides. After 6 days in the inpatient setting, her lipid panel had substantially improved and demonstrated a total cholesterol of 126 milligrams per deciliter, HDL of 12 milligrams per deciliter, and a triglyceride level of 526 milligrams per deciliter. The inpatient team subsequently discharged her home with a basal bolus insulin regimen, icosapent ethyl 2 grams twice daily, and continued her antiretroviral therapy. Her oral contraceptive therapy was discontinued to avoid estrogen-containing products, which may worsen triglyceride levels. 4 weeks later, she came to see us in clinic. She had shared with us that she had adopted a pescatarian dietary pattern, but was still eating a lot of fruits and sweets. She was not exercising regularly, and her repeat lipid panel showed a total cholesterol level of 184 milligrams per deciliter, HDL of 34 milligrams per deciliter, and a triglyceride level of 500 milligrams per deciliter.
Well, I'm really glad to hear that she's been trying hard to change her dietary habits. It looks like we might have a little bit of an issue with the fruit and the sweets, just because of that fructose content of some of those. But unfortunately, it seems like we do still have some work to do in order to prevent her from having another episode of acute pancreatitis. So, can you tell us a little bit more about her outpatient follow-up?
The first thing we did was ensure that she had a visit scheduled with a registered dietitian who specializes in lipid disorders. We also recommended that she start an exercise program with a goal of working up to greater than 225 to 250 minutes a week of moderate intensity aerobic activity, with the goal of achieving weight loss in accordance with recommendations from the American College of Sports Medicine. It is worth noting that triglyceride elevations are sensitive to exercise. We stopped her icosapent ethyl and started her on fenofibrate, as fibrates are more potent triglyceride-lowering agents. Given her triglyceride elevation, persistent risk factors such as HIV, diabetes, and PCOS, as well as having already suffered an episode of acute pancreatitis, one could make the case that it would be reasonable to start her on both fibrates and icosapent ethyl. However, we decided through a shared decision-making process to treat with fibrate monotherapy, as the patient wanted to minimize the amount of medication she was taking. We ordered a repeat lipid panel as well as an ApoB and lipoprotein A level to be done in 12 weeks, with a follow-up appointment scheduled at that time. During her visit, we discussed the appropriateness of considering alternate forms of contraception, although the triglyceride-raising effect is generally smaller with estrogen-progestin combinations. Ultimately, we decided to refer her to her GYN team to discuss non-estrogen-containing contraceptive options. We did consider genetic testing. However, given that her chylomicronemia was likely multifactorial, the decision was made not to pursue genetic testing at this time.
Yeah, I think that shared decision-making process is critical in patients like this. So there's definitely a lot to consider when we care for the patients in the outpatient setting. So I think it would be a great time to discuss some of the causes of chylomicronemia syndrome and then the approach to both the lifestyle and medical management in the outpatient setting. So Michael, can you take us away on that?
Sure, chylomicronemia syndrome can be multifactorial or familial. Familial chylomicronemia syndrome is often discovered very early in life, and patients have loss of function in one of the several genes involved in regulation of triglyceride metabolism. These genes include lipoprotein lipase, ApoC2, ApoA5, LMF1, and GPI-HBP1. Multifactorial chylomicronemia syndrome is the most common cause of chylomicronemia syndrome. It is usually the result of a clustering of genetic variants, including heterozygosity of one of the 5 genes previously mentioned, as well as more frequent variants with small effects in more than 40 additional genes that have been implicated. Having a genetic variant plus an aggravating factor will often exacerbate the metabolic defect and lead to chylomicronemia syndrome. Finally, patients with familial lipodystrophy may also develop chylomicronemia syndrome. The reason is not entirely understood, but it is thought that the reduced ability to deposit free fatty acids in adipose tissue, as well as accelerated lipolysis, might contribute to hypertriglyceridemia. With regards to medical management, the first step is to remove any aggravating factors. This would include dietary habits, excess alcohol, and any medications that may exacerbate hypertriglyceridemia. After this, the choice of therapy should be centered around whether the goal of therapy is ASCVD risk reduction or reducing the risk of acute pancreatitis. Often the optimal strategy is to start the patient on triglyceride-lowering therapy prior to discharge while in the hospital to prevent recurrence. Fibrates are the first-line pharmacotherapy when the goal of treatment is to prevent acute pancreatitis, especially when triglyceride levels are greater than 1,000. The ability of lipoprotein lipase to clear triglyceride-rich lipoproteins becomes saturated at triglyceride levels of approximately 500 to 700 milligrams per deciliter. When the ability to clear triglyceride-rich lipoproteins is impaired, dietary fat intake can lead to large increases in blood triglyceride levels. Those with triglycerides greater than 1,000 are at particularly high risk of acute pancreatitis. Fibrates stimulate PPAR alpha and primarily decrease triglycerides via upregulation of lipoprotein lipase. The reduction of triglycerides from fibrates ranges from 25 to 50%. Some data suggest fenofibrate may be more effective at lowering triglycerides than gemfibrozil. Gemfibrozil is the only fibrate therapy that has shown reduction in cardiovascular events in the VA HIT and HHS trials. However, it is worth noting these trials were not performed on background statin therapy, which is now contraindicated in patients taking gemfibrozil due to an increased risk of rhabdomyolysis. Prescription omega-3s lower triglycerides, possibly via decreased activity of SREBP1C. These are less potent reducers of triglycerides, with reductions ranging from 10 to 50%. While icosapent ethyl, a purified form of EPA, does have triglyceride-lowering effects, it is primarily used for ASCVD risk reduction in individuals greater than age 50 with triglycerides greater than 150 milligrams per deciliter and a history of ASCVD, or those without ASCVD, but with diabetes mellitus and multiple risk factors. This is based on the aforementioned REDUCE-IT trial. Briefly, REDUCE-IT randomized patients having moderate hypertriglyceridemia and a history of ASCVD or diabetes and other risk factors on background statin therapy to receive icosapent ethyl or a placebo. Patients in the icosapent ethyl group experienced an 18.3% reduction in triglyceride level compared to a 2.2% increase in the placebo group, as well as a 4.8% absolute risk reduction, and 25% relative risk reduction in the primary endpoint, which was a composite of cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, or unstable angina with a number needed to treat of 21. The therapy was associated with a slight, although significant increase in the risk of atrial fibrillation, which occurred in 5.3% of patients receiving icosapent ethyl, compared to 3.9% in the placebo group. There was also an increased risk of bleeding, which approached statistical significance. In this case, our patient does not exactly fit the study population investigated in that clinical trial. Other omega-3 fatty acids include mixtures of EPA and DHA, such as omega-3 acid ethyl esters and omega-3 carboxylic acids, which are often used to reduce the risk of pancreatitis in those with triglyceride levels greater than 500 milligrams per deciliter. Combined EPA-DHA products have been investigated in several trials, including, but not limited to, Strength, Vital, Ascend, and OMEMI. However, none of these trials have shown any significant reduction in cardiovascular endpoints. Given our patient's age, persistent risk factors, and previous episode of acute pancreatitis with triglycerides persistently greater than 500 milligrams per deciliter, we decided through shared decision-making to first lower her triglycerides with fenofibrate. Statins are primarily used for reduction of ASCVD risk, although they do lower triglycerides primarily through increased clearance of VLDL via upregulation of the remnant receptor. The 2021 ACC Expert Consensus Decision Pathway for Hypertriglyceridemia recommends initiating or intensifying statin therapy for patients aged 40 to 75 years with triglycerides of 500 to 999 milligrams per deciliter and either a 10-year ASCVD risk of greater than 5% or diabetes mellitus. While our patient may also benefit from statin therapy for primary prevention, given her history of diabetes and risk-enhancing factors, including HIV, her age being younger than 40 years does not place her firmly into one of the 4 statin benefit groups as described in the 2018 ACC AHA Multi-Society Guideline for Management of Blood Cholesterol. These guidelines further elaborate that in adults 20 to 39 years of age with diabetes mellitus type 2, statin therapy can be considered if they have type 2 diabetes for more than 10 years, albuminuria, defined as greater than 30 micrograms of albumin per milligram creatinine, an EGFR of less than 60, retinopathy, neuropathy, or an ankle brachial index of less than 0.9. Our patient did not have any of these risk-enhancing factors. However, we did order an ApoB and lipoprotein A level to help further assess her risk of ASCVD and to aid in making treatment decisions in the future.
In addition to statins, fibrates, and prescription omega-3s, I definitely recall a huge buzz at ACC 2024 when we talked about some new triglyceride-lowering agents. The field of lipidology is rapidly advancing, and it feels like it's a golden age for patients who need this kind of care. So it seems like every year we're hearing more and more about therapeutics that we may be soon adding to our armamentarium from a clinical perspective. Spencer, would you mind telling us about additional therapies that are currently being investigated for patients with chylomicronemia syndrome?
Of course, I'd be happy to. So there are several novel therapies that are being tested. 2 therapies that were really highlighted at ACC 2024 was plozasiran and olezarsen. Plozasiran was showcased at ACC with the result of the Shasta-2 trial presented. Plozasiran is a small interfering RNA drug against the ApoC3 RNA, which we had mentioned earlier. The results of the trial showed a significant decrease in triglycerides, was relatively well tolerated with only mild to moderate serious adverse events, none of which resulted in drug discontinuation. Interestingly, there was an increase in LDL-C, but ApoB remained constant and non-HDL cholesterol decreased in those who were in the drug group. Olezarsen was another drug that was showcased. Olezarsen is a modified antisense oligonucleotide that blocks ApoC3 production and has shown effectiveness at reducing triglyceride levels in patients with familial chylomicronemia syndrome. In clinical phase 2b trial Bridge TIMI 73A, olezarsen significantly reduced the levels of triglycerides, it reduced ApoB and non-HDL cholesterol, with no major safety concerns identified. olezarsen was granted orphan drug status by the FDA in 2024, which are two new drugs that are showing significant effectiveness with good safety profiles. Evinacumab is a very interesting drug, which is an angiopoietin-like 3 protein inhibitor. As we mentioned earlier, angiopoietin-like 3 protein inhibits lipoprotein lipase, which allows lipoprotein lipase to be less active, resulting in higher triglycerides. This was successfully implemented for the treatment of familial hypercholesterolemia, showing efficacy of LDL-C lowering in the ELLIPSE trial in patients with homozygous FH. It is a monthly infusion, and this drug is currently under investigation for the treatment of familial chylomicronemia syndrome for its triglyceride-reducing effects. Lastly, volanesorsen is an antisense oligonucleotide inhibitor of ApoC3, which reduces triglyceride levels by 70 to 80% and reduces the risk of pancreatitis. This was in the APPROACH trial, which was published in the New England Journal of Medicine. However, it was rejected by the FDA, and that was due to a safety concern for increased incidence of bleeding and thrombocytopenia. So ultimately, it did not come to market.
Well, now that we've discussed how we should approach managing these patients from a pharmacologic perspective, I think it's time to take a deep dive into perhaps the most important aspect of management for these patients, nutrition therapy. Anna, why don't you share with us how you would approach this patient when she comes to see you in your clinic? Do you have any guidelines that help you?
Absolutely. And thanks for mentioning, nutrition therapy is so essential for these patients with hypertriglyceridemia. It may sound kind of funny, but working with patients with hypertriglyceridemia is one of my favorites because they're actually so incredibly responsive to nutrition therapy. And our outpatient dietary interventions are always going to be individualized based on the patient. And we do have excellent guidelines published in 2023 titled Nutrition Interventions for Adults with Dyslipidemia, a Clinical Perspective from the National Lipid Association. So these guidelines lay a really solid framework, but we always use a patient-centered approach and incorporate their preferences, their cultural background, financial resources, and food availability when we take these guidelines from the paper to the palate. So I like to start by identifying the factors in the patient's diet that can dramatically raise triglycerides, which would include foods rich in added sugars, refined starches, saturated fats, and alcohol. So our patient is already doing good on the alcohol part. She doesn't drink, she doesn't smoke. And so at this point, I'll perform a detailed nutrition assessment to find out where the main problems are when it comes to what is raising the triglycerides, and then work with our patient to target those factors right away so that we can achieve dramatic and rapid reductions in triglycerides. The National Lipid Association guidelines create 4 categories of dietary management based on the severity of the hypertriglyceridemia and whether or not the patient has FCS. So these categories are 1 for triglyceride levels between 150 and 499 milligrams per deciliter, 2, the triglyceride levels between 500 and 749, 3, triglyceride levels above 750 with suspected multifactorial chylomicronemia syndrome, and number 4, triglycerides also above 750 with familial chylomicronemia syndrome. So a great first step for all patients with elevated triglycerides is to strive for an overall healthy dietary pattern like a Mediterranean or a DASH diet. A more targeted approach will then involve reducing or avoiding added sugars, refined starches, and the alcohol. When triglycerides are above 500, we also place a limit on the total dietary fat intake. We should advise all of our patients with elevated triglycerides to maximize plant sources of protein like beans, peas, and lentils. They should also maximize their intake of high fiber veggies. They should limit or avoid beverages with added sugars like soda, sweet tea, lemonade, and flavored milk. And then also limit foods with added sugars like sweets, ice cream, sugary cereals, and other snack foods with added sugar. We also want to limit full-fat dairy products, but we do want to encourage fat-free dairy products as they are tolerated by the patient. And lastly, we want to encourage all patients to perform at least 150 minutes per week of moderate intensity exercise or 75 minutes per week of vigorous exercise, but increasing the exercise up and above this threshold will continue to have added benefits.
Wow, thanks, Anna. You mentioned that they should avoid sugary drinks, but can you tell us a little bit more about alcohol and saturated fats and how that might impact some of our patients?
Absolutely. So, for patients with triglycerides above 500, the NLA recommends completely abstaining from alcohol. And then for triglycerides below 500, the recommendation is that men should not exceed 2 standard drinks per day, and women should not exceed 1 standard drink per day. 1 standard drink is the equivalent of 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of liquor. And we want to limit or avoid alcohol because alcohol increases the secretion of VLDL, it impairs lipolysis, and it also increases free fatty acid fluxes from adipose tissue to the liver. So, in general, it's really best to advise all of our patients to limit their alcohol as much as possible. Then for saturated fats, these not only raise triglycerides, but also LDL cholesterol. So those should be replaced with unsaturated fats whenever possible. And foods high in saturated fats include butter, red and processed meats, tropical oils like coconut oil, palm oil, and palm kernel oil. A thorough review of how our patients prepare their food should also be performed because making simple changes like cooking with olive oil rather than butter or rather than coconut oil can also improve the triglycerides and the LDL. It's also important to keep in mind that different cultures may have certain cooking methods that are higher in saturated fats, so the patient and the dietitian can work together to come up with alternative ways of cooking recipes that are lower in saturated fats but still retain the right flavors for their preferences.
Wow, it sounds like paying attention to detail is critical for dietary management. Now, what are some of the details for the four different categories of hypertriglyceridemia?
Sure. So let's start with mild triglyceride elevation and work our way up. When triglycerides are elevated between 150 to 499 milligrams per deciliter, we want to prioritize overall lifestyle modification because at this level of triglyceride elevation, we often see multiple metabolic risk factors, including but not limited to insulin resistance, elevated waist circumference, low HDL, and hypertension. The approach here is centered around reducing adiposity if they have excess adiposity, while also identifying and reducing the dietary factors that contribute to elevated triglycerides. So these patients should consume a moderate fat diet with about 25 to 35% of their total daily calories coming from fat, with most of that fat intake coming from the heart healthy mono and poly unsaturated fats. Alcohol should be limited. And then we also want to emphasize vegetables, fiber rich whole grains, beans, peas, lentils, nuts, and seeds, fatty and lean fish, and lean meats and poultry within the context of an overall healthy diet and exercise regimen. Moving up to when triglycerides are between 500 and 749 milligrams per deciliter. With this, the macronutrient targets are individualized. We want to start with a limit on total fat intake to 20 to 25% of the total daily calories coming from fat. And that's due to the fact that the triglyceride clearing action of LPL is significantly impaired once triglycerides reach a level of about 500. Chylomicrons and VLDL cannot readily be removed from the plasma at this point, so they start to accumulate. I like to explain it to my patients like the lipoprotein lipase is like the scissors that break down the fats in their bloodstream. And at a point of about 500 for triglycerides, those scissors get clogged and they can't keep working. And so plasma triglyceride levels can increase dramatically under triglyceride levels of about 500, even after just one high fat meal. So actually, however, many patients can achieve triglyceride reduction with dietary fat intake in the range of 20 to up to 40% of the daily calorie intake, especially when they're coming from unsaturated fatty acids. But other patients might need a lower fat diet at less than 20% of their total calorie intake for a few of our patients, at least to help maintain their triglyceride levels below 750. And we do expect quite a bit of variability in triglyceride response to differing levels of fat, protein, and carbohydrate intake based on the underlying metabolic drivers of hypertriglyceridemia. At a level of 500 to 749 milligrams per deciliter, we also encourage a healthy dietary pattern with greater emphasis on foods that are rich in lean proteins, dietary fiber, and unsaturated fatty acids like nuts, seeds, legumes, fish, and seafood, and those non-tropical liquid plant oils. These patients should minimize or eliminate the sweets, desserts, and dried fruits, fruit juices, and sugar-sweetened beverages because of the fructose content, and then definitely limit or avoid the alcohol. When triglycerides are above 750 and the patient has presumed multifactorial chylomicronemia syndrome, we will initiate a chylomicron clearing diet. This is a very low-fat diet with less than 5% of calories coming from fat for about 1 to 4 weeks to reduce the levels of circulating chylomicrons. And ideally, there will also be a calorie deficit. This one's pretty restrictive. There's no alcohol, no fruit juice, soda, or sugary drinks, no sweets or desserts like cakes, candies, cookies, pies, pastries, or ice cream, no added sugar, syrups, or honey added to foods, beverages, sauces, or condiments, and they'll also need to avoid refined food like white flour, white bread, or white rice, sugary breakfast cereals, and most store-bought snacks. This is where nutrition therapy can get especially challenging in practice, so it's essential to show empathy for what our patients may need to change about their current dietary habits and support them in making even small changes to start out with. So we've kind of covered what not to eat. Now I want to expand on what they should eat. So they should include plenty of high fiber vegetables like leafy greens, broccoli, Brussels sprouts, asparagus, and cauliflower. Encourage high fiber whole grains like oats, quinoa, brown rice, and bulgur. Starchy vegetables like corn, potatoes, and sweet potatoes can be included, but these are typically limited to 2 servings a day or less. We also recommend up to 2 servings of whole fruit per day, but limit dry fruits. These patients should also limit full fat and sugar-sweetened dairy products and instead opt for low-fat or fat-free, unsweetened dairy, including milk, cheese, and yogurt. We want to emphasize plant proteins, especially those beans, peas, and lentils, and we can cautiously include nuts and seeds in small portions. Finally, these patients should aim to include at least 2 servings of either fatty or lean fish per week and should opt for lean meats and poultry while avoiding the processed meats like bacon, sausage, and hot dogs. For flavor and variety in meals and snacks, these patients can use spices, herbs, vanilla, vinegars, fat-free broth, mustard, fat-free mayonnaise, zero-calorie sweeteners, sugar-free gelatin, and defatted powdered peanut butter. A practical strategy that works really well for my patients is framing the chylomicron clearing diet as a budget for total fat, which is typically around 15 to 20 grams of total fat per day. One of the benefits of this short-term restrictive dietary plan is that we see very rapid results when patients adhere closely to these dietary guidelines. I typically see anywhere between a 50 to 80% reduction in triglycerides with the chylomicron clearing diet. This can be extremely encouraging to the patient once they get their labs back and realize that their lifestyle modifications really made a huge difference, even in such a short time frame. So after following this plan for 1 to 4 weeks and triglyceride levels are well below 750, dietary fat intake can be cautiously liberalized with close monitoring of their triglyceride response. Finally, let's take a look at our patients with triglyceride levels above 750 and familial chylomicronemia syndrome. These patients must maintain a diet that limits total fat intake to less than 10 to 15% of their daily calorie intake for life. The budget method for total fat is also very effective here, with a typical budget of about 15 to 20 grams of total fat per day. To put that in perspective, just 1 tablespoon of olive oil has 14 grams of total fat. So even though olive oil is one that has the heart-healthy unsaturated fatty acids, for patients with FCS, it's actually not healthy for them. Now, similar to multifactorial chylomicronemia syndrome, those with FCS will also need to avoid added sugars, refined starches, and alcohol, and emphasize the high-fiber veggies, whole grains, whole fruits, plant proteins, and fat-free dairy. Lean fish and very lean cuts of meat and poultry can be selected for protein sources, along with beans, peas, and lentils. One main difference between MCS and FCS is that FCS requires the avoidance of fatty fish, nuts, and seeds due to the high fat content, again, even though those foods are rich in the unsaturated fats. Because the FCS diet is rather restricted over the entire life course, our patients may run into issues with maintaining a healthy weight and could also develop micronutrient deficiencies especially of the fat-soluble vitamins A, D, E, and K. If additional calories are needed to prevent excessive weight loss and maintain their lean mass, then we can consider supplementing with small amounts of medical grade medium chain triglyceride oil. And it's absolutely critical that the MCT oil is medical grade because this ensures that it contains only the medium chain fatty acids capric and caprylic acids. Non-medical grade MCT oils contain lauric acid, which is largely metabolized through a chylomicron-dependent pathway, and it actually may increase triglycerides. These guidelines can be really challenging for patients with FCS to maintain long-term, so the NLA recommends that all patients with confirmed FCS should be referred to a qualified registered dietitian nutritionist. So, in summary, for these dietary modifications for elevated triglycerides, we want to emphasize an overall healthy dietary pattern like a DASH diet or Mediterranean diet. Definitely cut back on sugar, refined starches, saturated fats, and alcohol. Emphasize fiber and lean animal or plant proteins. And then we also will limit total fat intake when triglyceride levels are above about 500 to 750 milligrams per deciliter. It takes multiple visits to implement all these guidelines because, as you can see, it can be a bit overwhelming. So I recommend starting with basic education on just reading nutrition facts labels. We want to start by identifying total fats and added sugars, which both have their own line on nutrition facts labels. The budget method works really well because it's simple. Patients get to retain autonomy around food decisions, and they also tend to buy in more to lifestyle modifications. When we say, your budget for total fat is 20 grams a day, you can choose how you want to spend it, but don't spend it all in one place. So teaching them to read nutrition facts labels and compare it to their nutrient budget improves their self-efficacy for using food as medicine and their ability to apply the guidelines in various settings. So in young patients like the one we're discussing here, the cornerstone of their management will definitely be centered around these lifestyle modifications.
Wow, Anna, that was a ton of extremely helpful information. Clearly, nutritional therapy is the backbone of managing these patients, especially in the younger population. Bringing this back to our patient, she clearly had a lot of areas of improvement in both her diet and lifestyle habits, and she would definitely benefit from close monitoring with a registered dietitian. I really can't wait to see how she's doing at her next visit.
12 weeks later, we saw her again for a scheduled follow-up. She has successfully lost 20 pounds by implementing the dietary changes recommended by our registered dietitian, with whom she's following routinely. She also started walking for 2 hours per day. Her lipid panel during this visit showed significant improvement, with a total cholesterol level of 185 milligrams per deciliter, HDL of 53 milligrams per deciliter, LDL of 111 milligrams per deciliter, and a triglyceride level of 104 milligrams per deciliter. In addition, her ApoB was 131 milligrams per deciliter, and her lipoprotein A was less than 10 nanomoles per liter. At this point, we congratulated her on all of her success and encouraged her to continue the incredible lifestyle modifications that she had made. That was a ton of information. Why don't we try to boil it all down to a couple of key pearls or takeaways? Spencer, can you share with us some of the top takeaways from this discussion?
Of course. So I think I'm going to give us some 5 really essential takeaways. The acute management of hypertriglyceridemia-induced pancreatitis involves prompt recognition and initiation of therapy to lower triglyceride levels using either plasmapheresis or intravenous insulin infusion with or without heparin. Insulin infusion is usually used more commonly, while plasmapheresis is preferred in pregnancy. Pearl number 2, medications such as fibrates and omega-3 fatty acids can be used to maintain long-term triglyceride reduction to prevent recurrence of pancreatitis, especially in patients with persistent triglyceride elevations despite lifestyle modifications. Statins can be used in patients for ASCVD risk reduction in patients with ASCVD risk than 5%, age greater than 40 years old, and diabetes, or diabetes with known or end organ damage or known atherosclerosis. Consider preferential use of icosapent ethyl as an omega-3 fatty acid for triglyceride lowering in the patients that fit the population that benefit in the reduce trend. Third pearl, apply dietary interventions to manage hypertriglyceridemia effectively with a focus on reducing when necessary and eliminating full fat dairy, fatty meat, sugar refined starches, added sugars, and alcohol, as well as encouraging patients to consume healthy foods such as high fiber vegetables, whole fruits, and plant based proteins. Pay special attention to the cooking oils to ensure the patient is not using palm oil, coconut oil, or butter when cooking. Fourth pro, recommend and encourage patients to exercise regularly with a minimum goal of 150 minutes per week of moderate intensity aerobic activity. And if weight loss is required, aim for a higher goal of greater than 225 to 250 minutes per week. And then our last pro, develop a patient-centered and a multidisciplinary strategy for preventing hypertriglyceridemia-induced pancreatitis through incorporating patient education on the importance of medication adherence, specialist follow-up, regular monitoring on triglyceride levels, and lifestyle modifications, as well as incorporating our registered dietitian teammates to maintain optimal lipid profiles. This is going to be essential to reduce their future risk of pancreatitis. Now, with the summary points being done, let's turn it over to our expert, Dr. Zahid Ahmad, Associate Professor in the Division of Endocrinology at the University of Texas Southwestern.
Hello, CardioNerds. I'm Dr. Zahid Ahmad. I'm an endocrinologist who specializes in lipid disorders at UT Southwestern Medical Center in Dallas, Texas. And I'm excited to join you for this discussion as the expert faculty for this episode. This case is actually a great case of very high triglycerides causing pancreatitis. And as you can kind of learn from the case, there's typically not one particular thing that causes the high triglycerides, but rather a whole bunch of associated conditions that kind of come together, and you get an increased production of VLDL triglycerides in the liver, as well as decreased clearance. You get saturation of the enzymes that clear triglycerides, and you end up with triglycerides in the thousands in pancreatitis. I'm going to just go over a few things about triglycerides, and I always like to start with a very basic thing, because this is confusing for not just us, but for patients. When I say us, I mean providers. There's also confusing for patients. Cholesterol and triglycerides are not the same thing. They're actually quite different. They just happen to be carried together in the same particles. Cholesterol is a kind of a unique structure. It's 4 fused hydrocarbon rings, and it forms a bulky steroid structure, and it's waxy. Triglycerides, on the other hand, are formed of 3 fatty acids on a glycerol backbone. And the fatty acids can dissociate from the backbone through the actions of different enzymes, and then reassociate through the actions of different enzymes. And that dissociation, reassociation actually ends up being very important, and that's the way the fatty acids can transport across cell membranes. And in patients like the one that's described here, this process of breaking up the triglyceride into 3 fatty acids and a glycerol is what's fairly defective. And I'll go into a little bit more detail in a few minutes about that. Generally speaking, when you eat food with fat, it gets absorbed into your intestine. It makes its way into chylomicrons, eventually into your circulation via the lymphatic pathway. And then it needs to be acted upon by enzymes to remove the triglycerides from the lipoprotein and into cells like adipocytes or hepatocytes, where they can be used for lipid storage or for energy. And that enzyme is lipoprotein lipase. I should mention the same, very similar pathway exists from triglycerides that are packaged in the liver into VLDL. Those also get put into circulation, and then the triglycerides are removed by lipoprotein lipase. Now, lipoprotein lipase is an enzyme, so it helps to understand a little bit or review a little bit about enzyme activity. So some of you may remember from high school biology the characteristics of an enzyme. An enzyme increases the rate of a chemical reaction, but it's not actually required. So you don't have to have lipoprotein lipase or any enzymes that break up the triglyceride or put it back together. However, without any enzymes, that reaction happens so slowly that we'd all become chylomicronemic, meaning we'd all have very, very high triglyceride. And enzyme activity is influenced by many things, including temperature and pH, or things like cofactor or coenzymes. So in the case of lipoprotein lipase, which is the main enzyme we're talking about, ApoC2, ApoA5, those are cofactors and coenzymes. There are things that activate enzymes. So for lipoprotein lipase, insulin and heparin are 2 things that speed up the process. And then there are things that inhibit the enzyme. And ApoC3 and ANGPTL3 are 2 proteins that do that. And you'll hear a lot about these You may hear of ApoC3 because there was a brand new drug that was just approved for patients who have mutations in the lipoprotein lipase enzyme. Such patients are referred to as having familial chylomicronemia syndrome. And there's an inhibitor of ApoC3 that actually works in these individuals to reduce their triglycerides. The drug is basically inhibiting an inhibitor, and as such, releases the enzyme to do a little bit more work. Now, another very key point that is probably what's happening in the patient described. Remember that an enzyme increases activity, but at some point, it just has no more capacity to take on more substrate, and it reaches its maximum velocity, which means that at some point, lipoprotein lipase just can't do more. And that's what happens to these patients like the one described here. We often call these patients as having multifactorial chylomicronemia syndrome. They keep accumulating these things that raise their triglycerides, and at some point, the lipoprotein lipase enzyme is just saturated. And at that point, the triglyceride levels just keep going up and up and up until the enzyme can eventually catch up, which it's very hard to do unless you keep someone on PO or you treat with insulin or other things as needed. People often ask me, what is the saturation point for the enzyme? Like, is it 1,000 milligrams per deciliter? That's a very hard question to answer, and there's not very good data. It's different in different tissues. In some tissues in the human body, the enzyme activity probably caps at around 500 milligrams per deciliter. In other places in the body, it might be much higher, maybe 800 or 1,000 in some tissues. Once you hit about 800 to 1,000, you just start accumulating chylomicrons. You have a clearance defect. And of course, the consequence of that is pancreatitis. Not every patient with high triglycerides gets pancreatitis, but it's thought that maybe there's a 15% increased risk when you do get triglycerides into the thousands. Now, in our clinic, we see a lot of patients with triglycerides in the thousands. About a quarter of them have had pancreatitis. And so that's probably, in a clinical setting, it's about a quarter of patients who get pancreatitis. And many of you probably already know pancreatitis due to high triglycerides is either the third or fourth most common cause of pancreatitis. One very important thing to note, in these patients who get pancreatitis from high triglycerides, if you look back in their chart, and this is published data, if you look back in their chart, you'll see that at some point previously, their triglycerides are closer to 500 or 600. That implies that when we identify people with a triglycerides of 500, we should address their triglycerides at that time and not wait for it to get worse. And there's no strong clinical trial or randomized control study data to kind of support that, but it seems like 500 milligrams per deciliter of triglycerides is a level where we should start taking it very seriously. And that 500 milligram per deciliter level is actually rather prevalent. From NHANES data, it seems like 1.7% of the population has triglycerides above 500. To put that in perspective, I often talk about Dallas Cowboys Stadium. Since I'm in Dallas, people here can relate to that. If you took all the people in Dallas-Fort Worth who have triglycerides above 500, you can fill up Dallas Cowboys Stadium. And the maximum capacity of the stadium, by the way, is 105,000. So there's no shortage of business if you're looking to treat people with triglycerides above 500. When you're evaluating these patients, there are some physical exam findings you can look for. If you're comfortable looking in the eyes, which in this case is actually pretty easy to do, you just need to visualize blood vessels. But if you're comfortable looking in the eyes, you can look for something called lipemia retinalis. This is a pale pink, almost white appearance of the vessels. It's due to light scattering of large chylomicron particles. So if you could just visualize any blood vessel, you'll be able to see it. Another thing that occurs in these patients is called eruptive or cutaneous xanthomas. And so these are actually triglyceride deposits in the skin. They show up as these crops of discrete yellow papules on an erythematous base, and they're often on the back or the buttocks or the extensor aspects of the elbows and knees. And the very interesting thing is when the triglycerides come down, these go away. I've seen a few patients where it might have left some scarring, but for the most part, in most patients, they just kind of go away completely. Another thing, if you took their blood, if you draw their blood and put it in a tube and just let the tube sit, you will see the plasma layer is milky, which is not normal. Plasma layer usually is not milky. And it's because triglycerides are causing the light to refract and it looks milky. And in fact, milk has a pretty high triglyceride content itself. I won't go into detail in case you are eating or something right now. You may not like to hear how much triglycerides milk actually has. And I think the discussion was fantastic with regards to the various different causes of high triglycerides. And why they occur, I wanted to touch on genetics a little bit. Most of the cases of severe hypertriglyceridemia are not monogenic. They're either polygenic or we can't really figure out what's going on. It's only about 1% of all cases that are truly monogenic, and most of those are due to familial chylomicronemia syndrome. Most of those cases are due to mutations in that enzyme, lipoprotein lipase. So if you have biallelic mutations in lipoprotein lipase, it is very hard to remove triglycerides from circulation. It's not impossible, but it's very hard. Unfortunately, such patients typically have very high triglycerides and pancreatitis from early ages. I've even seen a 6-month-old who had triglycerides of 6,000 and pancreatitis. But that's only 1% of cases. The likelihood that you see one of those cases is rare unless you happen to work in a center that gets a lot of referrals like ours does. Most of the other cases are genetically undefined. About 30% might have a very high polygenic risk score for triglycerides, and maybe 10 to 15% have heterozygous mutations in the genes that cause familial chylomicronemia syndrome. So to get familial chylomicronemia syndrome, you have to have biallelic or homozygous or compound heterozygous mutations. But some people, like the kids of those patients who have familial chylomicronemia syndrome, they will have just one mutation. The other gene will be fine. It's very interesting. Most of those people with a heterozygous mutation are fine. They don't actually get high triglycerides. But let's say they get some other hit, like diabetes or obesity, then they can start getting very, very high triglycerides. The same is actually true for people with high polygenic risk scores. By itself, a high polygenic risk score doesn't predict who's going to get very high triglycerides that well. But in the context of a second or third or fourth issue, for example, diabetes or hypothyroidism or obesity or alcohol use, the people with high polygenic risk scores can get very high triglycerides. Now, we don't usually recommend genetic testing unless you really suspect familial chylomicronemia syndrome. And you should suspect that if someone has no associated conditions, like they don't have diabetes, they're not on medications like estrogen that might raise triglycerides or something like that. But generally speaking, if you don't suspect familial chylomicronemia syndrome, genetic testing doesn't have much utility. It doesn't always change management. The one exception might be in cases of genetic lipodystrophies. Now, these are people who have no subcutaneous fat, yet they have all the manifestations of obesity. They'll have very high triglycerides, they'll have uncontrolled diabetes, they'll be at a high risk for cardiovascular disease. And in some lipodystrophy syndromes, there are specific treatments, but those are also quite rare. Just keep in mind, if you examine a patient and their arms and legs look muscular and the veins are popping out, that would be a good indication that the patient might have lipodystrophy. Now, in terms of treatment, I think the discussion was fantastic. We always want to address any associated conditions. If they have uncontrolled diabetes, obviously we really want to fix that. If they're drinking alcohol and you can get them to abstain, oftentimes the triglycerides come down to normal. If they're on medications like estrogen, then maybe stopping estrogen will help. If they're hypothyroid, then obviously, addressing hypothyroidism will help. Diet is rather confusing in these patients. Generally speaking, if someone's triglycerides are in the thousands and we consider them very high risk for pancreatitis, that would be someone that we really want to focus on an extremely low-fat diet. That's kind of a tough diet to do, but not impossible. It involves taking in only 15% or less of your energy from fat. And there are some good websites that go into that. You can look up knowyourtgs.com, and they have some dietary advice that's actually quite good. There's a bunch of treatments that we don't use very often that I think are worth talking about. We don't use plasmapheresis very often. There really isn't that much evidence that it reduces severity without causing complications. The list of complications include things like worsening anemia, hypothermia, hypocalcemia, hypotension, infection, bleeding. And so really we only consider these in the most severe cases. We definitely don't do plasmapheresis on an outpatient basis. The reason for that is because, yes, it does work. It'll reduce triglycerides by 85%, but the triglyceride levels will just go back up the next time they eat. Other things that we don't really use just to lower triglycerides are LDL-lowering drugs. So statins, ezetimibe, PCSK9 inhibitors, bempedoic acid, bile acid resins, those drugs don't have much of an effect on triglycerides. In fact, bile acid resins have the opposite effect of what you want. They can actually raise triglycerides. And so you definitely want to avoid that. You will also see niacin listed as a triglyceride-lowering drug. However, I often take patients off of niacin if they're referred to me on it because it does raise glucose, which probably could raise triglycerides. And then niacin, as you all know, is rather toxic. It's really fallen out of favor. We also don't use heparin. Even though heparin activates the enzyme lipoprotein lipase, there is a risk of hemorrhagic pancreatitis. And there's also this theoretical risk that it kind of exhausts all the existing lipoprotein lipase. That's a bit confusing to understand, but just know that heparin probably shouldn't be used. Whether or not you should use drugs like GLP-1s or pioglitazone, that's a little up in the air. Everyone is practicing a little bit different and it seems to be shifting a lot. I think now we're feeling more comfortable with using GLP-1s in people with very high triglycerides. If they have obesity and diabetes, GLP-1s would be an ideal drug. But as many of you know, there is this risk of pancreatitis that's kind of obscure, but it is there. Orlistat is an over-the-counter weight loss drug, and it's available as brand name Ally. It's something that patients can just buy themselves, and it actually seems to work for lowering triglycerides. Some of my colleagues at UT Southwestern did a study in a few children with familial chylomicronemia syndrome and showed that orlistat can actually reduce their triglycerides in half. That's a big deal. It essentially works by reducing the fat absorption in dietary intake. Now, this is the only weight loss drug that actually reduces caloric intake. All the other weight loss drugs reduce appetite. So it's an interesting drug to use, and I do use it in some people with very high triglycerides that don't seem to be responding to anything else. So quickly, in summary, when you see people with very high triglycerides, make sure you identify the underlying etiologies or associated conditions like uncontrolled diabetes or alcohol use. Take a look for signs and symptoms of high triglycerides like lipemia retinalis, eruptive adomas, and lipemic plasma, and then treat with like a low-fat diet. Use things like insulin and glucose infusions if they're admitted in the hospital with pancreatitis and have diabetes. Use triglyceride-lowering drugs like fibrates and omega-3s. And for patients with familial chylomicronemia syndrome, and eventually patients with persistent chylomicronemia, there are these ApoC3 inhibitors that are emerging and really are giving patients new hope as to lowering their triglycerides and reducing their chance of pancreatitis. Thank you all for having me. I really do appreciate the opportunity to give my 2 cents. I look forward to learning more from the cardio nerds.
Thanks for tuning in to another Cardio Nerds episode. The audio editing for this episode was performed by me, Pacey Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeComm Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.